And so this is another tubular pedunculated polyp. And on this film, this is where it was. Difficult, very difficult. And but having said that, the idea is, these kinds of film was very popular in maybe 15, 20 years ago, and they can still be shown for the simple reason which I have told you. So this is another polyp. Okay. Now, what is happening in this bowel? What do you think is happening?
So that's again provided with the double contrast railway enema and follow through, in which I can see there is multiple polyps are present involving the transfer as well as a descending colon. And
so this is a barium enema. You said a follow through. Maybe you meant an enema, right? So
yes.
Now you've picked up polyps. What are you going to advise? What is your diagnosis and what are you going to advise?
So as there are multiple, so I'm keen about the familial adenomatosis polyposis syndrome. So polyposis syndrome, I'm concerned about the familial adenomatosis polyposis syndrome. So I will further go for family screening or colonoscopy.
Right. So the point is that in there are same patient. What is this? And where is it?
So that's in the stomach.
Mm-hmm.
So multiple filling defects along with surrounding contrast. So that is a fundus of the stomach and multiple polyps. So I'm concerned about hematomatous polyposis or varices.
Excuse me, this is the same patient as the previous one. So how do you explain this finding?
Okay. So I can see there is a multiple filling defects are noted in the which is giving the along with the contrast uptake surrounding them. So in the stomach as well, along with the colon. So that's the polyposis syndrome again.
So what kind of polyps are you expecting in the stomach?
So they are most likely inflammatory or hematomatous.
Where else can there be polyps?
In the duodenum or small intestine. And
so how are you going to manage? What kind of polyps are you expecting in the duodenum?
In duodenum, Peutz-Jeghers syndrome, there are adenomatosis and the polyps which are along with the colon, they are usually associated with familial adenomatosis polyposis. And
okay, let me take over. You see, the point is that FAPS is an extremely important film for your examination. And you should have an absolute clear-cut idea about various kinds of FAPS. And the most important ones are, this is page 606 in your book, as in familial adenomatosis polyposis, adenomatous polyposis, and this one Gardner syndrome, and they come in the exam again and again. And the other ones are in the list, some of which I have cut from here. Now, point to remember is that polyps can be, other than colon, polyps can be in other part of GIT. Look here, extracolonic polyps, stomach more than duodenum. Now, in all of these, they can become malignant, particularly in the duodenum. And the key thing is that we have to understand that we have to do endoscopies to keep them under control. associated with other types of tumors which are here. In FAPs, all of them will develop carcinoma by the age of 40. This is a Viva question. What are you going to advise? Colonoscopy, and of course your answer was correct. Whole of the family should be again advise colonoscopy. Second thing is that ultimately all of them will have colectomy. And in Gardner syndrome, again, very, very important for the exam. You have to understand that all of these things are associated with Gardner syndrome. Once you know this, you can see which kind of long cases can come in your exam. And if you don't know it, you might get something in, let's say, an OPG, a denticulous cyst and with that, there might be an osteoma in the sinus, and with that, something in the large bowel. So if you don't know this, you are not going to get the answer of your long case. Okay, this patient had previous surgery 15 years ago. And now has presented. This is a delayed film of a follow-through examination. And what is happening here? What do you think?
I think so. There is some fistula formation.
Okay, I'll show you the CT of the same patient. So actually, if you see something is sitting here in the mesentery, and the small bowel loops are wrapped around it. So there is some soft tissue. So it's become a story type of case. So what do you think is the story then?
So with the history of the FAP, the most common appearance of this soft tissue density lesion is suggestive of desmoid.
Okay, so this patient now, please remember, look at this, desmoid tumors. Desmoid tumors of the mesentery, of the abdominal wall, of the soft tissue. So these are extremely important. Now, so what has happened, that there is evidence of surgery. Apparently this patient had a total colectomy, and now there is a tumor which is sitting in the mesentery, and this is displacing the small bowels around it. This patient has got, this is a 12-year-old child. I just wanted to show you the appearance of desmoid on an MR. So if you see here, this is a T2 weighted sequence, and you can see that this is low in signal intensity on T2 weighted sequence. So desmoid means fibrosis, just like a fibroid of the uterus. So it is low in signal on T2 weighted sequence. Okay, this is your last case, candidate 1. Can you describe it?
So that's the double contrast film in which I can see there is apple core appearance in the right ascending colon with the shouldering and narrowing of the lumen. So this shows with the background of multiple polyps in the rest of the colon. So this shows there is a development of any adenocarcinoma along with
this on a subsequent film became absolutely normal. So this was a spasm which got clear. So I am not interested here. Can you tell me what is happening in the transverse colon, for example?
So transverse colon is a bit dilated. However, in the background of I can see there is a multiple tiny filling defects are noted. So the multiple polyps are noted in the transverse colon, and the look. So are we concerned about
Is this transverse colon normal?
No, this is not normal. There are multiple polyps, which looks like pseudo polyps. So in differential, we may include ulcerative colitis.
Okay, fine. Thank you. So you can mute yourself. You should be ready. And I'm going to now tackle this film to teach you the teaching points on this film. Now, first of all, whenever you get a barium examination, may it be a solo or a, whatever it is, stomach or large bowel, small bowel, and you see some stricture or something, you have to ask the examiner that I want to confirm it on a subsequent film. You can, please remember, this is standard practice in barium films. Whenever you see a stricture, it might be because of technical reasons. The technical reasons might be that at that particular point, the loop might be collapsed. And this is something which they check in the exam. So you can tackle it in two ways. First of all, you can say that I want to check it in a subsequent film, or you can be more diplomatic and you can simply say that I assume that this was persistent in subsequent films. So the examiner is going to guide you, but you have to always, that's a rule in barium. Because, things like linitis plastica in stomach, you can make a fool out of yourself for the simple reason that at that point, it was underdistended. Now, what is happening is this is a film of ulcerative colitis. I'm going to show you many films of ulcerative colitis and also Crohn's disease. Now, if you go back to your pathology, please remember the difference between the two. Ulcerative colitis is a disease which just involves the large bowel. And on the other hand, Crohn's disease can involve anything in the GIT. Pathologically speaking, the main difference between the two is that ulcerative colitis is just superficial. So it will produce superficial ulcers. On the other hand, Crohn's disease is a transmural disease. So it goes through all layers of the GIT, and that's why it will cause fistulas and things like that. So the point is that if you just 1 second, why is I have muted everybody and even I can hear something. There is a bit of a technical issue at my end because I've muted everybody and I can even then hear a few voices. So be careful if you can please mute yourself, all of you. Now, so transmural versus superficial, and this helps you make radiology. So deep ulcers will be seen in Crohn's disease. On the other hand, in ulcerative colitis, it will be quite superficial. There will be no fistulae in ulcerative colitis. There will be fistulae in Crohn's disease. Skip lesions is Crohn's disease. Ulcerative colitis will be continuous disease. Now, if you look carefully, what is happening? So this is one teaching point here. This was a pseudostricture. If you see the transverse colon, it has got a granular type of pattern. If you see the hostra are slightly blunted. They are not very crisp and sharp. So this granular type of pattern is because of superficial ulcers. So basically, this is a classical example of what I call develop your eyes. So if you have seen it, fine. If you have not seen it, then you won't be able to pick it up. Candidate 2, can you raise your hand, please? So, can you hear me, candidate 2?
Yeah, I can hear you.
Okay, now, how do you describe this?
suitable barium contrast enema, demonstrating loss of hostia and visualized sigmoid descending transverse and visualized ascending colon on this single spot film. This almost kind of lead pipe kind of appearance of the colon. There is probably some.
So what is your conclusion?
The features are consistent with ulcerative colitis.
Okay, so why does this, how do you explain this appearance of lead pipe? What happens?
Because of, I presume because of the pre-existing superficial ulcers and the blending of hostia, I think over the long period of time, the colon kind of get a bit of fibrosed, or that's my assumption. But I probably don't know the underlying pathology.
Okay, so this is very good that you have used the word fibrosis. And please, if you open our textbook, it will always tell you that fibrosis is not a feature of ulcerative colitis. So this is what I was trying to teach you. So good that you have raised that issue. So please remember, there is no fibrosis. How do we explain this? What happens in ulcerative colitis? And this is a classical example of you know your pathology and you can make the radiology out of it. What happens that this is normal. Normal is mucosa. Under the mucosa is muscularis mucosa. Then is the submucosa. Then is the muscularis propria, and then of course the serosa. Now, what happens in ulcerative colitis? There is hypertrophy of the muscularis mucosa. If you see, this is it and how thickened it is. This is what happens. With that, in the submucosa, there is deposition of fat. And so what happens is that muscularis mucosa is a longitudinal type of, in orientation, it is a longitudinally oriented muscle. So it gets contracted, and that is why it becomes ahostra, it becomes shortened, and it gives you this kind of lead pipe appearance. And on cross-sectional imaging, as in a CT scan, if you see here, look at this rectum, and here you can see that, let me change my mouse. You can see that there is a fatty layer, and there is a submucosa, and then is the muscularis propria. So this gives you that target type of appearance, and the lumen will be narrow because the mucosa is thickened and everything is thickened. This is, again, fat in the ascending colon cecum because of the same thing. So this is the mechanism of development of the lead pipe appearance. Now, candidate 2, this is a lateral film of which area?
I can see the sacrum. So it should be either ileocecal area.
What is this?
Sorry, it's rectum and rectosigmoid junction.
Yeah. So this is the rectum itself, right?
Yeah.
So the Foley's is within the rectum, and here versus this. How just try to describe this film for me.
So it's a single spot image, lateral view of the barium enema with the Foley's in place in situ. There is a kind of featureless appearance of rectum. I think that's what I can see. I cannot see any polyp or any mass or any constriction on this single spot image. That's what I can describe.
Okay, so this film, in old days, this was quite a favorite film. Now, less likely. Having said that, you have to know everything. Basically, what is happening, that this is the rectum, there is Foley's inside. This is known as the pre-sacral space. and there is widened presacral space. In the difference between this film and this film is that on this film there is an associated fistula, and here there is no fistula. So widened presacral space is a differential diagnosis. In your board Chapman, it is given that at the level of S3 to S5, if it is more than 1.5 centimeter, this is the distance between the rectum and this bone. If it is more than that, we call it widened presacral space. And there is a differential diagnosis, and this is all the differential diagnosis. But in ulcerative colitis, it can happen because of a lot of inflammation or edema in the presacral space. This, on the other hand, candidate to if there are fistulae, then what will be if this is an IBD, inflammatory bowel disease, out of ulcerative or Crohn's, what is basically in Crohn's you can have fistulae also. So the idea to show you these films was the concept of pre-sacral space. On a CT scan, many other things are there which can be asked in the exam, and you can read it from this 7.29. Okay, this is a spot finding, and I just want you to answer this. If you look carefully, this is a transverse colon, and you can see a unique type of an appearance here. If you see this thing.
Yeah. So it's a spot film, Barium spot image, which is demonstrating multiple areas of filling defect, giving the kind of appearance of rose thorn ulcers.
Okay, rose thorn ulcers. You see, that is why I'm showing you this. Rose thorn ulcers are deep ulcers. And you use the word rose. I'm going to show you very shortly rose thorn. And I showed you in small bowel. Rose thorn ulcer means it is a very deep mural ulcer, giving you, if you see it in profile, it will give you a rose thorn appearance. This particular ulcer has got a very unique shape, like worm-like, filiform. And if you look carefully, then look at the hostra here, and you will appreciate that the hostra are lost. And this is a classical appearance of chronic polyps. These are actually technically pseudopolyps in IBD, and particularly seen in ulcerative colitis. And if you see, this is from your book, I've just pasted that here. Acute and chronic. Chronic, it resembles, these are known as filiform polyp, worm-like branching pattern. Why the examiners show you? Because this film tells you a story. And what is the story? Story is that this patient has got ulcerative colitis, but right now is in a quiescent stage. This is the story. And that is why it becomes a very important film. And so the idea is to develop your eyes to pick up these sessile or worm-like polyps. This, on the other hand, just to revise, if you go back, inflammatory polyp in acute stage, these are actually pseudopolyps, and these are explainable on grounds of mucosal hyperplasia. And this film you had done in your plain abdomen, so I'm not showing you plain films today. Having said that, just wanted to make that point. If you see here, this is a normal abdomen. Look at the transverse colon. Look at the crisp and sharp outline of the hostra. And here, what is happening? This is a case of toxic megacolon. And then how will you describe it in the exam is that you are going to tell the examiner that there is dilated long segment of transverse colon, With that, there is loss of hostra. There are thumbprints, so where I'm pointing out. And look here, what is projecting inside. And this is what we call pseudopolyps or acute inflammatory polyps. So this is nothing except for mucosal hyperplasia. What do you call this appearance?
So these are proper thumbprints.
Thumbprints. So basic idea is, I've shown you thumbprints in small bowel also, and this is mucosal edema. There is a bit of differential diagnosis. Practically anything can cause thumbprinting, like all of these ulcerative Crohn's, etc., and even neoplasia. Okay, what do you think is happening here? How do you describe this?
Again, there is kind of filling defect, superficial filling defect in the probably transverse colon. The hostra are a bit widened and slightly blunted.
Pointing out, sorry, I'm cutting you because of the time factor. So, what do you think is happening? Just describe this abnormality to me.
A couple of hyperdense spot surrounded, adjacent to a bit of radiolucent area. In the background of IBD, this could represent areas of pseudopolyp.
You see, the idea is again to show you, radiological findings which you can pick up and you can describe that what it is. You have described it extremely well, that there is contrast pooling and surrounding that is a lucency, means edema, and this is aphthoid ulcer. You remember it, isn't it? Aphthoid ulcer, do you remember candidate 2?
Yeah. So aphthoid ulcer, heard about in the stomach?
No, but I told you in the stomach also that aphthoid ulcer is a pathognomic ulcer, which is a deep ulcer. And when you see an aphthoid ulcer, means deep transmural type of ulcer. Means if it is in colon, if it is in small bowel, if it is in stomach, esophagus, the top differential will be Crohn's disease. And so this was just to show you aphthoid ulcers in the large bowel. Another case where you can see these aphthoid ulcers. So please remember the difference between aphthoid ulcers and the granular pattern which we saw in the colon in ulcerative colitis. That was superficial. So if you use the word aphthoid ulcer and if the examiner tells you what can it be, then don't go into ulcerative colitis because it cannot cause aphthoid ulcer. Simple as that. Okay, over to you. This is a very good film and I want you to describe it so I'm going to give you time. Please describe it.
So it's a barium enema spot film, double contrast barium enema spot film, which is demonstrating abnormality centered in the ascending colon and a bit of transverse and descending colon as well. There's mucosal edema in terms of thumbprinting, quite marked thumbprinting in the ascending colon. There's also some filling defects associated seen in the ascending and transverse proximal transverse colon. That is plenty flexure as well, and also in the proximal descending colon. There's also some aphthoid ulcer as well, if I can see, especially in the transverse colon, distal transverse colon, and the spiny flexure. Appearances are
to the distal terminal ileum.
So distal terminal ileum is a bit narrowed as well.
So what is your conclusion?
So the appearances are quite suggestive of inflammatory bowel disease with terminal ileitis.
do you mean inflammatory bowel disease? Choose the name.
Just on the basis of this, if I exclude my abscess ulcer finding, then terminal ileitis is more associated with the ulcerative colitis. So just on the basis of terminal ileitis and the appearance of the bowel, I think I was probably overcalling abscess ulcer if I am taking my words back. In that scenario, it should be ulcerative colitis.
Okay, I'll take over. You see, there are all of the features in this film are in keeping with Crohn's disease and are not in keeping with ulcerative colitis. So what are the features which are in favor of Crohn's disease? First of all, deep ulcers. And if you see, these are in profile. So this is a classical rose thorn. This is a classical rose thorn which is going, you can imagine that this must be the thickened bowel and the ulcer is going in. And when you see it in profile, it goes into the wall. Now, terminal ileitis is, terminal, don't confuse with what we call backwash ileitis in ulcerative colitis, where you can see a bit of inflammation there. On the other hand, classically, Crohn's disease involves the terminal ileum. And even in this terminal ileum, if you see where I am pointing out, and this one, these ones are rose thorn ulcers. They are deep ulcers. Even here, you can see deep ulcers. With that, you can see skip lesions. Now, skip lesions is pathognomic of Crohn's disease. This part of the large bowel is abnormal. This is normal, then abnormal, then normal. And in ulcerative colitis, by the way, within the colon, it can just involve, first of all, it can involve all of the colon, usually. It can also involve just the rectum. It can involve the left side of colon also. But there will never be these skip lesions. There will never be these deep ulcers. So this is a classical case of Crohn's disease. Okay, over to you.
Indeed, this is a spot film of triple contrast barium enema, which is demonstrating stricture in the mid-transverse colon, also in the probably hepatic flexure. There's also suggestion of some abscess ulceration in the distal transverse colon.
What's your conclusion?
So conclusion is the findings are quite in keeping with Crohn's disease.
Okay, this case is a more chronic case of Crohn's disease, where you can see these fibrotic stricture here, and the idea was just to show you another stage of the same disease, and of course, is one of the one of the pathognomic findings. And please remember, as we have covered initially, lead pipe appearance is not fibrosis. That's different. And this is different. Yes, please. What's happening here?
So it's a sigmoid colon with quite marked stricture. With a bit of ulceration as well, So there's an apical kind of stricture. I cannot see the shoulder though. I cannot see the rest of the bowel. Visualize descending colon appears normal. So there's abnormality centered at the sigmoid, in the sigmoid colon, with the very thin stricture, string-like stricture. It's a short segment. So differential here could be malignant stricture, or if it's a part of the disease process, then it could represent an inflammatory bowel disease. But I'll have to see the rest of the images.
Now, this mucosa where I am pointing out, you can see the mucosa. It's going up and down, up and down, up and down. You have also said that I could not see. I think you mentioned apple core, but you could not see any mucosal destruction.
Yeah.
Now, do you agree that there is no mucosal destruction?
Yeah, there's no mucosal destruction.
So then, what is this? 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 What is this?
These are circulations of polyps, kind of coming out of
outside the lumen. So what will it be? And you see it in each and every patient, you know.
Divertically, or diverticulitis.
Can you correlate the two then?
Yeah. So appearance are keeping with diverticulitis stricture because of diverticulitis.
Now you're using two different terms here. Now I'll take over. You should have a very clear-cut idea about what happens in diverticular disease. This word should be in your vocabulary: diverticular disease, then diverticular stricture, then diverticulitis, or you can say complicated, diverticulitis when you see fistulae. Those of you who are logged in from overseas, please remember that diverticular disease is one of the most common diseases in UK. And for example, in part of Asia, for example, subcontinent, etc., you don't see diverticular disease the way you see it here. And I remember when I used to do a barium enema list, I have not seen any list in which all patients might not have a few diverticuli. So there must be some genetics and there might be some dietary factors. And that is why for your exam, it's one of the most important films, diverticular disease and the complications of it. So when there are diverticuli, there can be diverticular stricture. And again, if you read your books, it will tell you that there is hypertrophy of the muscularis propria. So where there are diverticuli, there is hypertrophy of muscularis propria. And it gives the outline of the mucosal outline a peculiar type of serrated outline. Actually, I can see the serrated outline here, but let me explain to you what happens. Look here. This is the CT scan of the same patient, and you can see, this high density thing is the mucosa, and you can see this thickened wall right and left, and you can understand let me change my mouse to a pointer form. Now you can see that how it, the mucosa goes up and down type of appearance. There is no destruction. So this is the peculiar appearance of a diverticular stricture. Now, if you see this MR, and it gives you this beautifully. So this is the lumen, and it gives you this hypertrophy of the muscularis, giving you this serrated outline. And your books tell you serrated outline. So I call it the Rambo knife sign. In my era, he was one of the favorite of Hollywood, I think 1983 or whatever, Rambo. So look at his knife. This has got this serrated outline. So similarly, serrated outline of the mucosa. Now, if you see another case, which is similar to the one which I showed you, and there is a stricture here, there are diverticuli, and how it gives you this serrated outline. Now, candidate 2, can you please tell me how are you going to handle this part of the findings, and what is your diagnosis for this part?
Yeah. So there's a mucosal edema, there's serrated outline of the muscular mucosa of the sigmoid colon. There's adjacent mesenteric inflammation, and I can see an extraluminal gas locule centered in that mesenteric fat stranding. Appearances are suggestive of localized perforation of diverticular disease, in keeping with acute diverticulitis with sealed perforation. I would check the rest of the CT to look for any other extraluminal gases. The patient needs to be referred to the general surgery urgently.
So what will be the management for this kind of finding?
They may choose to manage it conservatively with antibiotic if it's just a single locule, and see how if it resolves conservatively.
Okay. Okay, fine, good. Now, the point is that this kind of appearance you might not find in each and every case, and in diverticular stricture, many a times in real world we are worried. We will just say that it is thickened, and we might ask for a colonoscopy, etc. The problem with colonoscopy is that many of these strictures are so tight that they might not be able to go through it. And I've got cases in my experience, we've got 4 or 5 cases in my hospital where we have been doing follow-ups just on MRs. And if you get this kind of an appearance, you are quite happy that there is no destruction going on. Having said that, coming back, please remember the main pathology which happens when we get diverticulitis. Basically, diverticulitis means that there is a perforation of a diverticuli. So initially there must be a perforation, and when the perforation occurs, there might be locule of gas. This locule of gas is sitting in the what we call the sigmoid mesentery, and there might be more than that. So don't overcall it. Don't think that this is pneumoperitoneum, because this is in the mesentery of the sigmoid. And then there can be many complications and abscesses, etc. And with abscesses, of course, in chronic diverticulitis or complicated diverticulitis, fistulae, etc. can develop, which come in the exam very often. Now, just to make my point, that this is a diverticular stricture, and this is a sigmoid colon, CA. So I'm not saying that in each and every case MR is so good or beautiful, but if you see this kind of finding, you are quite confident that there is no tumor. In the real world, it will be more gray area. Now, this is a case of complicated diverticular disease where you can see these diverticuli. There is a abscess formation here. Candidate 2, viva question. How will you manage?
We are selected axial slices of the pelvis, deep pelvis.
I have given you the finding. You just give me the management. There is abscess, and this is complicated diverticular disease. My question is, how will you manage? This is a viva question.
Needs to be referred to the surgeons, but it can be managed radiologically as well.
What are you going to offer to the surgeons?
It can be drained through CT guidance. Okay. Under the CT guidance.
You had your IR session, and just to make a point is that in these kinds of films, they will ask you, and please remember the concept that if there is an abscess, usually it's interventional radiology they go for. They don't do laparotomies. And they've got some criteria, clinical, but we're not going into that world. But generally speaking, most of the surgeons, they think that up to 5 centimeters, they will be more happy to go for IR help. And in your viva, once you say that, then the examiner might ask you some questions about IR, which you have already covered. This is a very, very good exam film. Over to you.
So it's a barium enema, a spot film, which is demonstrating a structure-like appearance of the sigmoid, with deep ulceration, and so there are some deep ulcers in the sigmoid. I cannot see any leakage of contrast around. I cannot see any polyps or diverticuli in the region. Appearances are quite suggestive of a stricture.
Okay, what's happening here where I'm pointing out? What is this?
So there's a pooling of contrast through. Okay, so there's a fistulation. So it's a fistulation through the anus, or ischio-anal fistulation, or anorectal fistulation. Yeah, it's a perianal fistulation.
Okay, I'll take over. Now, this is an extremely good exam case And the same case can come to you on other modalities like CT, etc. also, similar cases, even MR. Now, here what is happening is that this is the rectum, this is the sigmoid colon. Now, if you look carefully, diverticulum here, diverticulum here, diverticulum here, diverticulum here, diverticulum here. So there are multiple diverticuli. With that, from here to here, there is a stricture. But if you look carefully, look at the mucosa. These are not deep ulcers. This is that serrated outline of the mucosa which we had covered. So this is a diverticular stricture. In this case, the first thing which you are going to ask the examiner, I want to confirm it on another film. So that is a must. Once it's confirmed, then what is happening? This is the rectum. So anterior to the rectum, the contrast is going out. And you go back to the anatomy, what can be anterior to the? So this is the vagina, and this is a female. So this is a recto-vaginal fistula. So basically, it's a classical story film. The story is that this is chronic diverticulitis or complex or complicated diverticulitis with a recto-vaginal fistula. Okay, thank you, candidate 2. Candidate 3, please raise your hand. Candidate 3, can you hear me?
Yes, I can.
Okay, over to you. This patient has had surgery beforehand, as you can see. Over to you, please.
So I've got a spot film from a double contrast enema in which, and I can see there's been previous surgery as well. And the sigmoid colon appears to have a smaller caliber compared to the descending, and the rest of the bowel, the transverse and the ascending, is of normal caliber, and where I can see the sigmoid colon, it's featureless, it's narrowed, there's no fistula or diverticuli that I can see. And so I'm thinking whether this is a stricture which is secondary to post-radiation, or what the patients had for the previous malignancy, which has now been surgically managed, and the patient's having radiotherapy.
Okay, fine. I'll take over. Okay, fine, good. This is a post-radiation stricture. Now, you have to again remember your pathology, and you can make your radiology from there. Basically, post-radiation changes are because of vasculitis. You know, small vessels of the gut, they will have inflammation. And this vasculitis will present acutely because, you know, there can be leaky capillaries, as well as there can be some hemorrhage, intramural hemorrhage, and there can be mucosal thickening, etc. But post-radiation change, unfortunately, it just goes on and on. And over the time, you can have fibrosis also. So there can be long segment strictures. You will see cases in which there can be chronic as well as acute changes. So there can be a bit of overlap. Overall, in the exam, they will always show you post-radiation where there will be some stigmata of old surgery today, you know, like this, or some other on a CT scan. Because they will show you as a story film, and you have to develop that story. And the story is that the patient had surgery. Usually, in large bowel, it is the sigmoid, the rectosigmoid, which is involved. The simple reason is that a lot of cancers in that area. In females, you know, the gynae cancers. In males, again, similarly. So the point is that rectosigmoid is the main location for this. On the other hand, is post-radiation, where you can see long segment, you know, more fibrotic type of stricture. But here, you can see in the transverse colon what is happening, that there is a lot of thumbprints, etc. So a bit of acute as well as chronic type of changes are there. Candidate 3, over to you. What's happening here?
So I've got a double contrast enema, because I can see all large bowel here. And I can see there's this loop of bowel in which there are ovoid areas where there's no contrast in it, and multiple lucent ovoid areas within the loop of bowel. The rest of the bowel is of normal caliber. So there isn't a halo sign as such, as a target sign to suggest there's an ulcer there. And I'm thinking whether these are multiple polyps.
And it's an Aunt Minnie case. Look at the profile here. Look at the wall. This is a hint.
There's edema as well. Is this a cobblestone kind of appearance?
Right. Okay. I'll take over. So this is actually I'd shown you similar cases in the plain abdomen one. This is nematosis coli. And nematosis coli, there is an entity in your book, nematosis intestinalis, benign, idiopathic. This is what we are talking about. Americans sometimes call this primary nematosis intestinalis. When it is in the colon, which is the most common, we call it nematosis coli. It can be in the small bowel, nematosis intestinalis cystoides. Nematosis cystoides intestinalis. Now, what is happening? First of all, remember idiopathic. So we don't know what happens. But basically, there are air bubbles sitting, neural air bubbles. These air bubbles are sitting within the wall, in this case, in the colon. And they give you this bunch of grape type of an appearance. It's an Aunt Minnie. If you see in the profile, some of these are extending outside because you are seeing them in the profile. And here they are projecting inside. And look at this plain film. On the plain film, it gives you that, again, that Aunt Minnie appearance. And look at the ones which are in the profile. Now, in our hospital, we have got a very interesting case in which I've got, CT is going back to about 10 years for this patient, who has presented with 2 times to our hospital with pneumoperitoneum without any peritonitis. So, because we knew what it is, nobody acted on it. Basically, you can imagine that these air bubbles can also burst and it can cause free air, but that free air will not cause peritonitis. So you have to know this, and this is because it's an Aunt Minnie case, it's an important case for the exam. Last film before I give you a 5-minute break. Yes, candidate 3, over to you.
So this was a double contrast enema which has been taken in a decubitus position, and I can see the large bowel is of normal caliber, and just looking at the ascending colon where there is some pooling.
Okay, very good. You have picked something up here.
Yeah, that, yeah.
And what do you think about this thing?
There's the multiple, like when the transverse ascending and then going all the way. And I can't see any in the descending. So, and there's pooling of contrast in them, so makes me think whether these are diverticuli or polyps.
Yes, you see, look at, they're quite wide-necked. They're quite big. Okay, let me give you a hint. This patient is under the care of the rheumatologist.
So whether these are inflammatory...
Rheumatology, hint again.
So they're white-based.
So it has to be a systemic condition, right? You are seeing a manifestation in the bowel of a systemic.
Thickened fold, or no, it doesn't look like a thickened fold.
Okay. So what comes to your mind? Oh, I've written it here. So that's a giveaway. But I'll take over. Thank you very much. And I'll give you a break after I give my explanation on this film. And after the break, it will be candidate 4. Candidate 3, thank you. Now, this is a case of scleroderma. By the way, this is a totally different case. But why I am showing you, because scleroderma is a very important exam case. And it comes in the exam again and again. You should understand various manifestations, and they will show you, because it's a multi-system, they can also show you as a long case. Now, this is what we are talking about. That film was decubitus. Here you can see these pseudo-seculations. Now, what happens? This is what we call hide-bound, just like skin, you can have hide-bound bowel in scleroderma. Basic pathology is that the muscularis propria is replaced by collagen and fibrosis, so it becomes sort of weak. So there is no muscle here. Because there is no muscle, it is replaced by collagen and fibrosis. There can be what we call pseudo-seculations. It just pops out like this and pops out like this. I have shown you this in small bowel also, where you could see pseudo-seculations at the anti-mesenteric border of the small bowel, and there was a peculiar type of finding where you can see a distended small bowel where there is crowding of folds. So I explained to you the pathology there also. So these are pseudo-seculations. In scleroderma, of course, they might show you with other stigmata of scleroderma, so you should know that. Okay, so I am now stopping here, and I am going to mute myself. This is going to be a 5-minute break, and we'll continue after 5 minutes. Can you hear, see my screen?
Yes, I can.
Okay, please, over to you.
So I've got sequential images of CT abdomen and pelvis with oral contrast. In the right iliac fossa, there is tubular thickening in the expected region of the appendix with an appendicolith with surrounding pericolic fat stranding. Features are in keeping with appendicitis. There's also thickening of the adjacent peritoneal reflection. I can't see any free air on these images.
Okay, fine, well done. Okay, good film, this one. Exam case, over to you.
So there is a well-defined mass in the left lower quadrant. It displaces the small bowel posteriorly. There is some metallic artifact through this region, but otherwise it is fairly of homogeneous density. There's no surrounding stranding. So my suspicion is that this is possibly the metallic bits of it confusing. I think this is probably a solid tumor with some sort of intervention that has occurred from it. Is there any sort of relevant history?
So the patient had some surgery in the past.
Okay, so it seems like possibly there is a, depending on what the surgery was for primarily, but could be either a tumor recurrence within the area of surgery, given the surgical clips. That this could be a seroma which has higher attenuation because of secondary infection. Given its presence in the mesentery, this could be something like a desmoid tumor or a peritoneal deposit.
Okay. This is what we call a gauzy pipoma, also known as a textiloma. Basically, it's a retained swab. A retained swab is a never event in UK, and there are robust mechanisms, because please remember to go back to the basics. The surgical gauze which is used is what we call barium impregnated. It has got a thread which is impregnated with barium. It's high density, and they have got robust systems to count, and after the surgery count it again, and if in doubt they will do a plain film there and then. Having said that, these kinds of things do happen. I've seen 3-4 cases in my experience. All of them were, had some surgeries abroad, and but you should be familiar with this. And the key thing is that if you do a plain film, you will see this high density to be metallic density as you have picked up. So once the radiology is quite tricky, because what happens is you can see there are small air pockets within this gauze. And it all depends. Sometimes you will get this, flocculent type of densities within it, and the air pockets can sit in for months and months. And sometimes it will be sterilized, and there will be no symptoms or anything. But the key thing is that metallic density. So think out of the box and think about a gauzy pipoma. This case has got, because of time factor, I am just going to ask you a leading question. Now, there is a developing intersusception. Can you describe it, and what do you think is the cause?
So there is an intersusception. It seems to be there is a fatty density adjacent to the intersusception. So I think the most likely cause is probably a lipoma.
Excellent. So this lipoma is the leading tumor. It has, if you see the mesentery is going in, this is the lumen of the intersusceptum, and this is the intersusception. And you can see that this lipoma is the lead point which has taken it inside. And in the exam, you will ask the examiner, I want to do my densitometer, and that will be, that will confirm that this is a lipoma. This patient was scanned for mesenteric ischemia, that was the history, acute abdomen. And this is an arterial phase. What's happening here?
There is hyperenhancement in the loops of bowel in the right iliac fossa. There's also kind of free fluid. It looks like it's confined to the peritoneal reflection.
So this was a loop of bowel. You are right. And within that, you can see this high density. Which phase is this?
It looks like it's arterial phase.
What should you be worried about, and what will you ask for?
So delayed imaging. It looks like there's contrast extravasation. So I'd want in portal venous or delayed phase, 90 seconds.
Before that, what is more important?
And then unenhanced to see if the high density was present before.
So unenhanced is the key. You have to ask for that. This is the unenhanced, and now what is your conclusion? That there is an active bleed. Your answer that I will also ask for a delayed is also a correct answer, because please remember that what happens when you do a delayed film, it will make the diagnosis even more certain. So for example, this patient had a polypectomy, and you can see this arterial phase, there is a bit of enhancement, so active bleed. Non-enhanced, there is nothing, and on delayed, it further spreads. So, but the key thing is to ask for a non-enhanced. Same scenario, they will also ask protocoling, because how will you protocol it? And these kinds of study, an unenhanced scan is critical. So this, I believe, takes us to the end of, no, still there are a few films. Okay, what is this?
So this is CT abdomen and pelvis in the portal venous phase. There is marked circumferential neural thickening of the transverse descending colon and the rectum. It has a there's also ascites, and it has a sort of a pseudomembranous colitis sort of an appearance with marked colonic thickening with mesenteric hyperemia and ascites.
Right. So well done. So basically, this film is pseudomembranous colitis, but it can be a differential diagnosis. Now, this is from your book, and you should have a clear-cut concept about some of these things which I have pointed out. Your book tells you that colitis can be diffuse. When colitis is diffuse, the top two are UC and pseudomembranous colitis. In pseudomembranous colitis, the thickening of mucosa, they say, is much more than anything else, but that is not absolutely specific finding. This is known as accordion sign, where look at this thickening and this is the mucosa. So other than pseudomembranous colitis, these things you have to remember, but UC, you should have a clear-cut concept about UC. So pathologically speaking, UC will involve anything, rectum proximally, but radiologically speaking, you will see in your clinical practice various kinds of patterns. And it can be diffuse, it can be predominant left-sided, ulcerative, and you might see UC, which is just rectal or proctitis is there. Other than that, predominantly right-sided Crohn's disease is important. Ischemic colitis. This particular type of ischemic colitis is a ischemic colitis where the SMA is involved. And if an examiner has this kind of a film, maybe on a CT, he or she is going to show it to you. Why? The concept. The concept is that, please remember that SMA supplies till about the transverse colon. So it is supplying the small bowel and the large side of the colon. It's quite a unique finding where there are signs of ischemia in the small bowel as well as right-sided of colon. On the other hand, usually ischemic colitis in the large bowel is on the left side, and this is because of IMA, inferior mesenteric artery. So diverticulitis we have already covered, and radiation we have also already covered. Whatever I have pointed out, these are important for your exams. I am going to just go through them quickly because I have taught you this in the abdomen part, where the idea was that I have shown you various kinds of films which can come in the exam where something is sitting on the serosal surface of the bowel and is causing a desmoplastic reaction. So because we have already covered it, I'm just going to revise it. This is a classical case of metastasis. The metastases are sitting at the rectosigmoid junction here, and this is ovarian metastasis. And what happens is that when something sits on the serosal surface, two things are important for the exam. One is metastasis, second thing is endometriosis. And so if you see what happens here, that it is causing some indentation on the lumen is narrowed. Because of the desmoplastic reaction, folds of barium are going towards the soft tissue mass, and the mucosal folds might be sort of fixed there. We call this striped colon sign. So metastasis sitting here, metastasis sitting here. Another case, and here you can see something is sitting here at the serosal surface of the rectosigmoid, but this one is endometriosis. Another example, and another example sitting at the ileocecal junction. I had also shown you this, MR, which is a very important exam case, where what is happening is that there is deposit of endometriosis at the rectosigmoid. Key finding is that this is low in signal intensity on T2 weighted sequence because of hemosiderine. In our case, there is a hysterectomy, and there is another deposit which is sitting on the posterior surface of the bladder. And you can well imagine that at the time of menstruation, this patient must be bleeding through the, there must be hematuria as well as melena. So same case is barium examination, and you can see this serosal surface indentation. And I also told you that malignancies, they appear high signal on T2 weighted or intermediate signal. So this is a deposit of the ovarian carcinoma metastasis, which is sitting there. Look at the signal. This is intermediate signal. This is low signal. So this is different than this. Spot diagnosis, candidate 4, just give me the diagnosis. What's happening? These two strictures, benign or malignant?
There is some shouldering and some mucosal irregularity, so I'm going to be malignant.
Excellent. So these are synchronous tumors, two tumors sitting there. Okay, final thing of this chapter is rectal carcinoma. How would you describe this?
So there is, on the sagittal, I can see circumferential but asymmetrical mural thickening of the rachmoid of the rectum with increased T2 signal. There is also some, it's eccentric and mainly between the 12 o'clock and 5 o'clock position. There's a bit of thickening of the mesorectal fascia. I can't see any surrounding enlarged mesorectal nodes. The the fat plane between the prostate and the rectum is preserved, and the bone marrow demonstrates normal signal intensity.
So you said that there is thickening of the mesorectal fascia. Which sequence are you talking about?
I think I can just see those linear kind of low intensity streaks, just kind of lateral to the rectum on the axial images.
So you're pointing out to this thing here?
No, just a bit more lateral. I can see those two lines just there, yeah. And the other.
What does this mean then?
I mean, it's not that thick. It means there's some sort of inflammation, but given the history, given the presence of that mass, then when you want to, in terms of surgery, you want to be telling them about it so they can excise, so they can have a clear excision margin.
So, what is the staging of this tumor, the T staging?
Oh, sorry, I don't have any ideas on that.
Okay.
But there is extra capsular, there's serosal invasion, because you can see it on the top, on the second axial imaging. It's the tumor infiltrates beyond the serosa, but it's separate from the seminal vesicle.
Within the mesorectal fascia, mesorectal fat, and is there any serosa at this stage? My question is anatomy.
Is there any serosa? I don't think so.
Then, okay, what I have, you see, the point is that rectal carcinoma, candidate 4, thank you very much. You can keep unmuted, but I'll take over. I'm going to teach you now about rectal carcinoma. Now, rectal carcinoma MR is now a pure exam case, and you have to understand, and it has come in the exam now quite a few times, and there can be vivas, etc. also on this. And in your day-to-day practice, those of you who are sitting the exam and they do not know how to report an MR, the best way is to learn something, which, for example, I'm going to teach you something today, and do about 5 odd reports under your consultants, so that before the exam you know what you have to and how to tackle it. So let me go back to the basics. I think I am reflecting on one thing today. I wanted to finish GIT, which was very ambitious, because I'm going to teach you liver also in great detail. And as I'm talking to you, I had not designed my next Thursday's teaching. And what I'm going to do is that I am going to go a bit slow. This is what I have decided as I'm proceeding through the session, and teach you more. And next Thursday, I'm going to continue with whatever is left. And that will give me the time to give you a bit of quality on the teaching, because this rectum carcinoma is very important, and it will take a bit of time. Then liver MR will take a bit of time. So I will not conclude GI, but time-wise I will conclude. I will just stop at 9 o'clock today. And then whatever is left, I will continue next Thursday. So now, if you see the sequences of MR rectum, these are the sequences, and this is what we do. This is what we used to do. We used to do a large field of view. When a case comes to you for rectal carcinoma, please remember, you should be given the histological diagnosis. So how does it happen is that the patient has already had a colonoscopy or a sigmoidoscopy. There was a tumor. They will give you the histological diagnosis. Number 2, they will tell you that what level is the tumor. So they will say in centimeters, it is X centimeter from the anal verge. and they have to tell you this. And one black and white concept which you should have, that our role of an MR of the rectum is not diagnosis, is a staging. Means that where the tumor is going and things like that. So I'll give you the concepts and the viva questions around it. When we stage a rectal carcinoma, we do local staging with an MR, and otherwise we do a CT, chest, abdomen, and pelvis for any metastasis. Now on MR, these are the sequences. We do large field of view, T2s, and so the pelvis, etc., is seen in a large field of view. Then we do small field of view. I'll come back to the small field of view subsequently. We used to do a few years ago some diffusion weighted also. Nowadays, studies have told us that there is no significant role of diffusion, and in our department we have discontinued, and I believe most of the departments have discontinued diffusion in rectal carcinoma. Now, if you see this case, you can see that there is a rectal carcinoma here, and so this is a different case and this is a different case. Now, key point is how will you orient your axial slices? And this is one of the key things which you have to do correctly. If you don't do it correctly, you will get false results. So the orientation is that the axial slice should be oriented perpendicular to the long axis of the tumor. So for example, look at this one, it's tricky. The tumor is starting from here and going here. Look at this slice here. If it is oriented like this, you will get this type of image where the edge will not be seen clearly and you might get some false finding. The false finding I am going to point out shortly. So what we do is that we will scan this in this axis and then another axis like this. So your radiographer should be trained to pick that up and give you axials accordingly, according to the long axis of the tumor. Now, anatomy is the key. Please remember that there is the peritoneal reflection. It stops at a particular location, and if you see, this is a male pelvis. On this male pelvis, this is the prostate, this is the seminal vesicle. If you see, this is the peritoneal reflection. Peritoneum is coming here and then going here. And on this slice, it is beautifully seen. Look at this. This peritoneal reflection attaches here. So distal to that is what we call the mesorectal fat and the mesorectal fascia, which I'll show you. But the peritoneal reflection is attached here. So this is a key concept, and this is an exam concept also. Secondly, the surgeons, when you're doing an MDT, will also ask you the same thing. So peritoneal reflection is attached here. Now, in a female, this is a female in which you can see that this is the uterus, and you can see that the reflection comes here and attaches here. So anatomy-wise, we are interested from here downwards. This is where the rectum is. Of course, part of the rectum can be just here also, and then is the sigmoid. So here, distal to that peritoneal reflection, this is the anatomy. The anatomy is that this is the rectum, and this rectum does not contain a serosa. Remember, serosa is that peritoneal reflection. Serosa is finished. And then here is a fascia, and this fascia is the mesorectal fascia. And then this is the mesorectal fat. Now, key thing is, if you concentrate on this diagram, it tells you T3 tumor. So this is the mesorectal fascia. T3 is a tumor which goes into the mesorectal fat. T1 and T2 will be confined to the wall of the rectum. T3 will go into the mesorectal fat, and that becomes an exam case. If a tumor goes to a mesorectal fat, it becomes T3. On the other hand, if the tumor goes into for example, any other pelvic organ, we call it a T4. T4 will be blatant, it will be evident. But T3 is where you have to develop your eyes on. So look at this. This is the tumor here, node here, and this thing all is the mesorectal fascia. This is the seminal vesicle. And if this tumor goes here, we call it is going into the mesorectal fat, becomes a T3 tumor. So this is the staging. T3 is invasion into the mesorectal fat. T4, invasion into the surrounding organs and structures, as well as the visceral peritoneum. So this question is asked in MDT. If you do an MDT with the surgeons at times where there is a high tumor in the rectum, this is what they are going to ask you. Is it superior to the peritoneal reflection or not? Key management question is, or management concept to remember for your exam is that if the tumor goes into the mesorectal fat, you do not do surgeries immediately. The concept is that you might like to do neoadjuvant chemotherapy or chemoradiotherapy. It all depends where you are working, because there are various theories in the oncology work. Usually they will give chemoradio for 6 months. So your report completely changes the management of the patient. And that is why you have to develop your eyes to pick up invasion of the mesorectum. And if you say it is invaded, then they will give new adjuvant chemo. Which in your report, which means distension of the vein, which will be, just like a vessel, serpiginous, and then it can be in continuity with the tumor, or it might not be in continuity. Extramural vascular invasion, don't confuse it with a lymph node. Lymph node is different. Extramural vascular invasion is different. And there is a lot of literature and a lot of research also going on. And people say that if there is extramural invasion, then there is 4-fold increase in risk of distant metastasis. And prognosis also is not very good. So prognosis-wise also it from 74% to 35%. In our report, if there is extramural vascular invasion, you have to pick it up. Classical exam case, I'm expecting that the examiner will show you extramural vascular invasion, just to check your concept on that. Another thing before I continue is to see this tumor. We use the word, we call it intermediate signal on T2 weighted sequence. Classical tumors are like this, intermediate signal on T2 weighted sequence. They are not very high signal, they are not very low signal. So if I go back and I just showed you that metastasis, ovarian metastasis sitting on the rectosigmoid, and look at this signal. This is intermediate signal on T2. When you will cover, gynae tumors as in CS cervix, etc., you will realize that this will be the signal. So now, this is how we should report an MR of the rectum. First of all, what is the distance from the anal verge? Now, please remember that this thing, the surgeons should tell you actually that this is the distance from the anal verge. Having said that, you can also sort of infer it on the imaging. Then you have to say what is the craniocaudal and the transverse extension. The transverse extension is also what we call the depth of the tumor. So how thick is the tumor or how deep it is, it has got some prognostic value there. Is it going into the mesorectal fat or not? For me, this is a classical exam case, and what we are expecting for you to be shown is this thing, extension into the mesorectal fat. Now, from here comes this concept of distance from the mesorectal fascia. Now, if the tumor touches the mesorectal fascia, then we use the word it is circumferential resection margin positive. The basic concept is that in surgery, what they do is they just remove whole of the rectum, including the mesorectal fascia. So the mesorectal fascia, mesorectal fat, and the rectum comes out of it. When it goes for histology, the histologist will say that was the circumferential resection margin positive or not. If it is positive, means bad news, because you don't know if it has gone beyond it. If it is negative, it is good news. Similarly, these terminologies can also be used in pre-operative MRs. And the concept is that if the tumor is as close as 1 millimeter from the mesorectal fascia, we can use this word circumferential resection margin positive. And if it is more than 1 millimeter away, then we call it circumferential resection margin negative. Many people do not use these words, but they just report it. They say that the tumor is abutting the mesorectal fascia, for example, or say that it is only 1 millimeter from the mesorectal fascia. Now, any pelvic organ involvement, if it is a T4 tumor, then you have to say that, it is going into the lateral pelvic wall or whatever. Are there any mesorectal nodes? You have to tell this. Is there extramural venous invasion? Are there any pelvic nodes? So mesorectal nodes are, of course, around the rectum, within the mesorectal fat, and other nodes are, other chains like obturator chain and external iliac or internal iliac chain, etc. Now, anatomy, I have already told you that you have to have clear-cut idea where is the peritoneal reflection, and in a male, this is the seminal vesicle. This thing goes here. So from here downwards is only the mesorectal fat and the fascia, and here onwards is here and more proximally is the peritoneum. If the tumor is sitting here, please remember, if the tumor is sitting here, they will ask you, the surgeons will ask you that is it superior to the peritoneum? Is something going into the peritoneum? Because if something is going here, staging wise, it becomes something else, right? It is gone already into the peritoneum. So this anatomy is critical. And in a female, you can see that it goes here and it is attached at the same location, but from the cervix, from the junction of the cervix and lower part of the body, you can see the reflection. Now, this is the case which we covered initially. Now, candidate 4, are you with us?
Yes, I am.
Okay, now I will point out a few things. If you see here, first of all, we have to tell the examiner what is the distance from the anal verge. So what we do is that this from here to here, and first of all on a sagittal we decide where the tumor is or what is the distalmost portion. So we add here to here on packs, and then here, for example, this is 3 centimeter and this is 3 centimeter. We say that it is about 6 centimeter from the anal verge, but please remember they should have already told you this. Then we measure the craniocaudal extent. So from here to here, and this, let's say we say that the craniocaudal extension of the tumor is 5 centimeter, for example. Then on a transverse cut, we say what is the location of the tumor. So this is the location. It is basically on the left side, anteriorly and on the left. Maximum thickness is this much. This thickness is also what we call depth. Then is it going into the mesorectal fat or not? Now you have to concentrate because this is the key exam point. If you see here, you can see this whiskering of some high signal or intermediate signal going into the mesorectal fat. You can see the same thing here. You can see the same thing here. So this is classical where you say that the tumor is extending into the mesorectal fat. Now, from here, you have to, the next question is there any extramural venous, invasion or, venous involvement? And you can see something happening here. You can call this that there might be some evidence of, you see this is thickened and this is distended, and look how, look at the shape. It is serpiginous. Then you have to tell that is circumferential resection margin positive or not. Now, if you see this is the seminal vesicle, and this is the mesorectal fat, the fascia. Now, is where I am pointing out, is this a tumor? Is this tumor or not? If this is tumor, then it is going and abutting it. So you will say that there is circumferential resection margin positive. So, and then are there any mesorectal lymph nodes? Now, mesorectal lymph nodes, for example, this small dot might be a lymph node. In the mesorectum, size criteria wise, radiologically speaking, 5 millimeter or more is taken as abnormal. But if you see surgical studies, they tell you that even 2 millimeters can be abnormal. And a better idea is to use a criteria where a lymph node, if it has got slightly heterogeneous signal, this is T2, which has got 2 different types of T2s. And then if it has got an irregular outline, then you would like to call it abnormal. So these are the criteria to or the things which you have to answer in the exam or in your day-to-day reporting. So here I am going to show you a case, and then I will show you 3 odd cases, and we will finish the chapter. So I'm going to show you case in a what I call a PACS type of format. Candidate 4, can you see this green slide?
Yes, I can.
Okay, so this is a case of T3 tumor in a case which is 51-year-old male. So I am showing you an axial slice here, and I want you to see it with me. Now, on this axial slice, this is, of course, the bladder. This is the seminal vesicle. And you can see that this is the mesorectal fascia, and this is your tumor. Now you can see till now, so I'm more distal. You can see actually the prostate here, and here if you see the wall of the rectum becomes looks normal, and then as I'm going superiorly, you can see that the wall becomes thickened. And now see the signal, and you will appreciate that this signal is intermediate. Actually, this is more or less a circumferential tumor. It is, it is a 360-degree type of tumor. If just from this slice, if you see here, and develop your eyes on this one, look at this. We call it whiskering. You see, where I am pointing out, this will be the muscularis. So something is going out. If I just show you this slide, you can be confident enough of saying that there is whiskering and the tumor is in continuity with the tumor here. So it is going into the mesorectal fat. And with that, you can see this. Look at this structure. It is just like a vessel. Look here. It is just like a vessel. So these two are intramural venous vascular invasion. But the same thing here. For example, there is another vessel which is, and same thing here, same thing here. Now, if you look carefully, this is the mesorectal fascia, and this tumor here is abutting it. And even here it is abutting it. So I will say that this is just on this point, this is circumferential resection margin positive. Now look at the lymph node. This is one lymph node in the presacral space. Look at the signal intensity. Where I am pointing out, the signal is slightly intermediate, and here it is slightly darker. And this is a classical example of a lymph node which is inward. So, so this is the axial. On axial, we have already concluded that this is a T3 tumor. There is vascular invasion. There are lymph nodes. Look at this one. This is also an irregular lymph node. You have to call it. And then it is circumferential resection margin positive. Now, going superiorly, you can see that rectum is just finishing and the tumor finishes here. And there is something here, but this something we will pick it up on a sagittal sequence. And then is the sigmoid. So we go to, here you are, there is another lymph node here. There is a lymph node here. There is a lymph node here. So these are those pelvic lymph nodes. Sorry, this one was not a lymph node. That was a vessel. So then we go to a sagittal. Actually, what I do is that I start from a sagittal, orient myself, and then I go to an axial. But because it had opened like that, I was just going through it. Now, if you see here, this is the anal canal. So from here onwards, you can measure this thing. For example, this is 3 centimeter plus this thing. You can say it is 6 centimeter from the anal verge. Then you measure from here till the highest point, which is here. And you tell them that the tumor is 7 centimeter in craniocaudal length. Now, key thing is orient yourself about the peritoneal reflection. This is the seminal vesicle, and you can see that it goes here and it attaches here. So the tumor is, and then there is another attachment here. The tumor is definitely going superior to the level of the peritoneal reflection. Now, what they are going to ask you is that is the tumor going into the peritoneal cavity? If I go to the parasagittal here, and look here. So if I correlate it with an axial, which I cannot because I am not on PACS, if I cross-reference it, definitely it is going out here. So this tumor is going into the peritoneal cavity. It's much more than a T3, it becomes a T4. And then look at this, there is a lymph node here, and then look at these lymph nodes. This is a lymph node, this is a lymph node. And of course, the involvement of various vessels, for example, this one, this one, this one. So it goes into the peritoneum. Look at this tongue. And this is that tongue of tissue which we were seeing on an axial. And you can see that disregard everything, whatever is happening here, but just concentrate on this point. And you will appreciate that here the tumor actually is touching the mesorectal fascia. So just on this ground, it becomes a circumferential resection margin positive. So these are the things which you have to look for on a MR of the rectum. And candidate 4, I'm going to show you another case, and then candidate 5, I've got 1 or 2 more cases for you. This is the small field of view of the same axial which I showed you. And here, just see that this is the seminal vesicle. See that the tumor here, and you can see some whiskers going and abutting the mesorectal fascia here, means that it is circumferential resection margin positive. And same thing here, because it is small field of view, you can see it much better. So it is all a bad news, and you can see the the lymph node here. Now, here in a PAX format, other than this rectum, I had also put a colitis case, and just to see that here is a CT scan. So for the time being, come out of rectal CA world, and you can see that you can see this is the transverse colon, and this transverse colon, there is mucosal thickening. So we will, I'm going towards the hepatic flexure, all mucosal thickening here, and then I am coming towards, this is the ascending colon and the cecum, and everything is thickened. On the other hand, if I follow it from downside, the rectum, the rectosigmoid, this was the sigmoid, and the ascending colon, etc., is all thickened. So candidate 4, what it is, as far as pattern is concerned?
The accordion sign.
Right. So this is a pseudomembranous colitis type of a differential. Of course, it cannot be 100% specific. The same differential is that in the exam you will also say that it can be what we call ulcerative colitis and other infective colitis, and this is a coronal of the same. Okay, I put in some cases, and these kinds of cases come in long cases. They are unusual cases. I think I'll just skip it because of the time factor. But what we will do is that when we will do our long cases module, then I will show you these kinds of cases which come in the exam. Here, this is an interesting one because there is a abscess sitting in the lesser lesser sac, and it is communicating with the duodenum, and then it is communicating here. You can see this fistulous communication into the colon, and this is a duodenocolic fistula with abscess formation. So these kinds of cases, at times they come in long cases, and you have to do practice of scrolling them on PACS and making the diagnosis. And in this particular case, when gastrographic enema was done, you can see that the fistulous communication into the duodenum and the stomach also filled up. It's a sort of a long case. In any case, I will now show you rectal CA And then we'll go to candidate 5. So candidate 4 is, candidate 4, are you with me?
Yes, I am.
Okay, can you see my screen?
I can do, yeah.
Okay. Now I am going to ask you leading questions on this case, right?
Mm-hmm.
There is a rectal carcinoma which is going. Is the patient male or female?
I think I can see the seminal vesicle, so male.
Male. Now, there is a tumor which is quite a, in a craniocaudal dimension, quite significant. Is the tumor going proximal to the peritoneal reflection or not?
It is.
And which slice do you want me to point out for that?
Probably the top right, so the third sagittal.
Yeah.
Or even the second, either.
Yeah, very good. Well done. If you see, this is the peritoneum and the tumor is going superior to that. Now, of course, without the cross-reference lines, it's very difficult to point out that at this particular location what's happened. But wherever we are here slightly more distal. What's happening? Is the tumor confined to the muscularis?
No, it's extension into the mesorectal fat.
Okay. Are there any lymph nodes?
There are some small lymph nodes, probably in the bottom axial duct slice, just posteriorly. You can see so on the second image, I can see there's a node there. Yeah.
Okay, and you can relate with them. So let's assume that there was no extension into the peritoneal cavity here. So with that thing, what do you think is the T staging?
So it would be T3 then.
Okay, is circumferential resection margin positive or not? Maybe just concentrate on this one first of all.
Yeah, so on that one, it is positive because anteriorly I can see some whiskering towards the seminal vesicle.
Right. Sometimes in our reports, we just say most of the people use this word circumferential resection margin is threatened, or they say, the mesorectal fascia is threatened. This word is also in vogue. But never never make your assumption just on the basis of sagittal. Once you pick it up, then confirm it on an axial. Here, I don't think so I've given you very good axials correlating with this, but I believe even here it is touching. Okay, well done. Thank you, candidate 4. And candidate 5, are you with us? I'm going to show you 1 or 2 cases and then we'll go for a 5-minute break. Okay, candidate 5, are you with us?
Yeah.
Okay, now, male or female?
Male.
Okay, so of course I have written here also, and prostate, you can see a tumor here. Just concentrate on this. What is happening? Just from this slice.
So there's bulky thickening of the rectum with extension of an intermediate signal tumor out into the mesorectal fat at the sort of 7 or 8 o'clock position. The tumor appears to be extending to the circumferential resection margin, so would be CRM positive. On the other images, we can also see at least 3 intermediate signal lymph nodes.
Right. So if you see here, mesorectal fascia is involved. This is a slightly difficult sequence because it is axial, but it is a longitudinal type of an, coronal axial type because it is through the long axis. You can see multiple lymph nodes. Another concept is that if the lymph node is touching the fascia, again you will call it, because of the location of the lymph node, you will say that circumferential resection margin is positive. Do you think there is any venous invasion somewhere, or you want to, extramural vascular invasion?
I think on the last image in the bottom right-hand corner, there's a sort of thick tubular structure running alongside where the mouse is that could be suspicious for extramural vascular invasion, but
right. So please remember that it has been mentioned in literature that this finding is undercalled in our day-to-day reporting. And it's not important, as I told you, as far as staging is concerned, but prognostic value-wise, it is. And they want us to report it because there are more than the chances of metastasis, for example, increases. Some of the tertiary care centers, like Royal Marsden Hospital, they are doing some research on this. And one of the hypotheses is that if you pick up extramural vascular invasion, then you should be more worried about liver metastasis. And here comes the sensitivity and specificity of a test. So some suggestion is that we should do an MR of the liver, and there they suggest just diffusion-weighted MR of the liver, which is more sensitive tool than a CT to pick up small metastasis. Okay, now this patient had previous, prostate surgery also. So here, just on this slice, what is happening? There is a tumor here. Is it going into the mesorectal fat?
it does look like there's sort of spokes extending into the fat.
Excellent. Now, the question is, this is a low tumor. If you see here, this is the anal canal, and the tumor is from here to here, and at the anorectal junction, you can see it. And due to that, there is prostate, and this prostate also had some surgery. This patient had some surgery. The tumor is here. Now, please remember that this is mesorectal fascia, and next to that will be what we call the fascia of the Denenwiller, where, this is the external to the capsule of the prostate. Now, what do you think? Candidate 5, just orient yourself on sagittals. And what do you think on this slide? How will you call it? Is it going into the prostate, or are you suspicious, or you are not?
I'd say you'd be at least suspicious that it's extending in. You haven't got any sort of intervening fat there to call it as not extending into the prostate.
Right. So if you see here, this is the outer line, and you can see something here. So this is the capsule of the prostate, and even here. So at least one can raise the issue that it is suspicious finding. And what happens is that the surgeons, they will then, it becomes a very complex surgery if they want to do the surgery, and they would like to involve the urologist also during that. So it's a very important finding. I cannot see. Okay, now I can see.
Hello.
Yeah, I can. Sorry, I think the problem was at my end. I am going to. What I have decided is that I'm going to cover a bit of liver, and then I'll go to pancreas, and the main part of liver, hepatobiliary, we will cover next Thursday. So that's the plan. Now, high speed now once again. This is a case of trauma. What's happening? Over to you.
So these are selected contrast-enhanced axial images of the upper abdomen for a adult patient. There's multiple hypodense linear areas throughout the liver, most likely in keeping with acute liver lacerations. I can't see any active extravasation of contrast on these images. But there is an impression of some free fluid around the liver.
Okay. The idea here was to, when in trauma world, the description is that we two words can be used. One is laceration when they are linear like this, and there is another word which we call intramural hematoma. So these are the two words. It is good that you were looking for any extravasation. Active extravasation is in the exam, usually they show it. Is there any active extravasation here?
Yes, I can see it on the second and third images. There's a blush of contrast.
Excellent. So in this case, what is happening, that there is trauma, and we can see that there are splenic lacerations and a lot of hematoma there. But the key finding is this one here. There is intramural hematoma, and with that, there is extravasation. So the viva questions will be around this. Once you pick that up, because this becomes an emergency, and the role of interventional radiology now, because they would like to do it conservatively, so the interventional radiologist can help with embolization, and they might ask you question, how will you do, which kind of materials can be used, etc. This is another case where you can see that splenic rupture and active extravasation. So always keep that in mind. Okay, what is happening in the liver parenchyma?
So these are selected axial images of a CT scan in the arterial phase. There appears to be contrast within both the arterial and venous system. There's also quite a lot of periportal hypodensity or edema.
Right. So the basic idea is that, arterial and venous system, of course, that's not the issue in this case. The issue was just to develop your eyes on this finding, which is what we call periportal edema. Now, sometimes what I have seen is that inexperienced, ST2s, let's say, at times they confuse this finding and they think that this is intrahepatic, biliary channel dilatation. If you go back to your anatomy, what's happening, the portal vein, always remember that the biliary system is anterior to the portal vein, anatomically speaking. It cannot be posterior. Here, what is happening, that anterior as well as posterior, you can see this hypodensity. And this is what we call periportal edema. In your latest Chapman, this is the differential 8.14. Periportal edema can be hypoechoic on ultrasound, hypodense on CT, hyperintense on MR. Basically, we are talking about a circumferential halo around the portal vein. So it will surround the portal vein, and there are so many causes. You know, a patient might have hypoalbuminemia and will have it. And a patient might have acute cholangitis and will have it, or cholecystitis will have it. Similarly, in trauma also, you can see it. So the idea is just to pick up that this is what is happening, periportal edema. So totally non-specific. Okay, now what I am going to do is that I am going to skip the liver component, and as I have told you that the plan is to come back to the liver and the biliary system next time. Okay, over to you, candidate 5.
So these are selected axial images of a contrast-enhanced CT study through the upper abdomen for an adult patient. There is a large abnormality in the spleen, which appears to be of fluid density with a thick enhancing rim. On the third image, there's also the impression of some internal contrast enhancement.
Yeah, actually, this is a bit of motion artifact. So,
okay.
So this is just calcification. So what will be your differential then?
So for a cystic splenic lesion, my differentials would include a splenic cyst, a pseudocyst, or an abscess perhaps.
Means if it is calcified, means that there was an abscess in the past. This is what you are trying to say?
Yes.
Okay. So basically, the idea here was to cover the cystic, the differential diagnosis of cystic splenic lesions. Pseudocyst is the most common, post-traumatic, etc. Sometimes you don't even have a history. And epithelial cyst, abscess, hydrated cyst, etc. This is just to cover the differential. And similarly, there is a differential diagnosis of solid lesions in the spleen, and the most common benign, and it can be divided into benign as well as malignant. Most common benign lesion, solid lesion, is hemangioma, and it will behave just like hemangioma of the liver, which we will cover next time. And most common solid malignant lesion is lymphoma, and also metastasis is up there. So this is the list from your book. Solid splenic lesion, non-neoplastic, benign, malignant. So the idea is just to cover this. This case has got calcification in the liver. Candidate 5, can you give me the differential diagnosis of calcification in the liver? Causes. That is the idea of this. Do you remember anything? Candidate 5, are you with us? You lost her. Yeah, I think we've lost her. Okay, so thank you, candidate 5. Candidate 6, can you raise your hand, please? Candidate 6, are you with us?
Yes, hello, Dr. Can you hear me clearly?
Yes, I can. So just give me a bookish differential diagnosis of calcification in the liver.
Okay, maybe mucinous tumor metastasis.
Mm-hmm.
Maybe fibrolamellar HCC.
Mm-hmm.
Maybe hydatid, although this does not look like hydatid.
Mm-hmm.
There's nothing else on my mind, but my first differential in this case is mucinous Smith's or pseudomyxoma peritoniae even.
Okay, so the idea here is just what can be, just to cover the calcification, and there are so many things which can calcify in the liver. And our case there was metastasis, and this was in this territory, mucinous metastasis, maybe from colon, and these are calcification within a mass like metastasis, fibrolamellar HCC, but there are other causes which are given here. So I'm skipping the liver part for the next time, and we will come back next time. So we go to the pancreas actually. Yes, please.
So there is marked swelling, edema, and fat stranding surrounding the pancreas, the entire pancreas. I'm searching for any areas of non-enhancement. I think it's most of the pancreas is enhancing.
What do you think? Compare this versus this.
Yeah. The body is slightly hypoattenuating in comparison to the tail.
So what does that mean? What does that mean?
Process, acute necrotizing pancreatitis.
Okay, well done. So when you see a case of acute pancreatitis, you must comment on two things. One of the things is visible on this case. Are there any non-enhancing parts of pancreas? Because that means that there is necrosis going on. I'm not going into staging, etc., because various centers use their own staging. But having said that, you have to point out that X part of the pancreas does not enhance in keeping with necrosis. And the second most important thing in acute pancreatitis is visible on this case. Over to you. This is a different case, please. Candidate 6, over to you.
Yes. Okay, so I can see air foci in the region of pancreatic head, which is also hypoattenuating in comparison to the rest of pancreas. So this is acute infection in the context of necrotizing pancreatitis.
Okay, so what do you suggest then? What will you like to do? How will you manage this case?
Yes, these cases usually needs surgical debridement and of course antibiotic therapy.
Right, so you can put in a drain before the debridement, right? So the point is that the first take-home point from this case is in acute pancreatitis, you have to look for any signs of secondary infection within that fluid around it. And if you see an air bubble there, call it. Simple as that. And in this case, there are multiple bubbles. And then, in these kinds of cases, they will ask you to put in a drain, and you can also offer, you can say that I'll offer to put in a drain. And then there might be some questions regarding interventional radiology. Over to you.
Okay, this is ERCP image with contrast filling the pancreatic duct. I can see evidence of surgical eclipse, possibly resembling cholecystectomy.
So this is unrelated and I'm not interested.
All right. So I cannot see the body or tail of pancreas.
Excellent. Well done.
In my normal practice, I tend to measure the common bile duct to make sure if it's dilated or not.
Okay, that's fine. I'm not interested. Please remember the bile duct is up to 1 centimeter post cholecystectomy is taken as normal, but I'm not interested.
All right. So
just interested in what's happening here.
There is abrupt termination of the pancreatic duct.
Mm-hmm.
Maybe there might be a tumor compressing the duct, maybe a congenital anomaly.
Okay, what kind of congenital anomaly do you think of?
Pancreas division.
Okay, excellent. Now, if you just concentrate on this, pancreas is developed from two buds. One is known as the dorsal bud, and second one is the ventral bud. The dorsal bud has got the main pancreatic duct, and actually it has got its own, technically speaking, an opening, accessory ampulla. But this is the ventral bud. The CBD comes with it. Normally what happens, it crossovers and sits here and then joins. You remember we also did a case of annular pancreas. But having said that, once it joins, now it is sitting here. The duct of the ventral duct is known as virsum. I remember it with the symbol of, the Volkswagen VW, ventral virsum. So this is how I remember it. Now, usually there can be many patterns. Usual pattern is that it joins with the main pancreatic duct, the dorsal bud. And one pattern is shown here where this thing also, the duct of Centurioni has got its own opening. Another pattern will be where this completely obliterates and there is only one opening. So all of these are possibilities. Pancreatic divisum is what is shown here, which is self-explanatory, that the duct of virsum has, it just ends here. And it is not in continuity and means that there will be two ampullas. And this is from literature, one MRCP examination showing the same thing. Pancreatic division is associated with chronic pancreatitis. So at times the gastroenterologists, they like our comments on that. Yes, candidate 6, over to you.
All right, so these are axial CT images with oral contrast. There is lipomatous transformation of the pancreas. The most common pathology to do is cystic fibrosis.
Excellent. So here, in the exam scenario, this kind of a case becomes very difficult to pick up because, something is absent and the human mind does not go into it. And basically, the pancreas is not there. It is all, there is just fatty, atrophy. And usually it can be seen in patient of cystic fibrosis, and it can also come in the exam as a long case.
Okay, so these images in the venous phase show marked dilatation of the intrahepatic biliary tree. And there is also dilatation of the pancreatic duct. This is a double duct sign. So there is actually heterogeneous, predominantly hypoattenuating mass at the region of head of pancreas. So this is, in conclusion, it's a pancreatic head adenocarcinoma with double duct sign, and this patient needs urgent drainage for this biliary system.
Okay, well done. So here what is happening is that this is the pancreas, and the pancreatic adenocarcinoma attenuates less than, it's a hypovascular tumor, so it attenuates less than the pancreas, and with that it is causing obstruction of the pancreatic duct as well as the CBD and intrahepatic duct dilatation is there also. So now we will go into the world of pancreatic tumors. And this is from your book. So many things can happen, but I will confine myself to some of the important ones from the exam point of view subsequently. Now, one point of technique which I want to elaborate is that pancreatic parenchyma enhances, maximum enhancement of pancreatic parenchyma is actually at 50 to 55 seconds. It's not a classical arterial phase. It's not a classical venous phase. It is somewhere in between. and hepatic phase is 65 to 70. Now, point to remember is that pancreatic adenocarcinomas are hypovascular lesions. So, literature tells us that if you want to pick up a tumor, you can use this phase, and your sensitivity of picking up a tumor can increase. It's more of a theoretical knowledge these days, not a practical knowledge, because we do not use CTs to pick up a tumor where it is not visible. Which modality is the king there? Candidate 6 for pancreatic. Pancreatic tumor which are not seen very well on CT, and you are seeing, let's say, a abrupt cutoff of a duct, or you are worried about a tumor. Then what modality will you go for?
MRI? TICAS, maybe?
No. King modality there. Okay. So hint, something like esophagus.
Then endoscopic ultrasound.
Yeah, endoscopic ultrasound. So in esophagus, you remember, and this is a Viva question, when you do TNM staging, for T staging, endoscopic ultrasound is routinely done. In pancreas, it's slightly different. You don't have to do an endoscopic ultrasound to pick up to do T staging, which I'm going to teach you on CT. On the other hand, if a tumor is not visible, endoscopic ultrasound is much better, and of course you can do a biopsy with it also. So first of all, this is a case where you can, just to make the point that this tumor, this is a 70-second delay and this is a 50-second delay, and you can see that the parenchyma is enhancing better, and you can see the tumor is better seen. Having said that, nobody does it. The king modality is EUS, and EUS, if you see that if the tumor is less than 2.5 centimeter, CT is 53% sensitive, EUS is 89. And on the other hand, if the tumor is larger, generally speaking, EUS is about 98%. So EUS is the king modality, and this is Viva question. Here is an example where there is a bit of duct dilatation, and you practically very difficult to pick up a tumor, but on EUS you can see the tumor there. Candidate 6.
Yes.
This is abrupt pancreatic duct cutoff. What is the significance of this sign?
And it can present a tumor.
Oh, yeah. So I warn you that this is one of the most important signs where you see a double duct sign is very easy because both ducts are dilated and means that the tumor is quite big. But I have seen many cases and many discrepancies in my life where this sign was missed, and retrospectively speaking, the patient had this sign. So if you see a portion of the main pancreatic duct dilated, you have to raise this issue. It should be discussed in MDT. There's a bit of differential diagnosis because the patient might have chronic pancreatitis. That's a different world. But the patient might have a tumor, and an endoscopic ultrasound might be the savior there. Okay, now as far as T staging of pancreatic tumors is concerned, the key thing to understand is T4 tumor. T4 tumor, look at it. You see, let me go back to, first of all, T3. So T3 tumor is tumor extends beyond pancreas. What is the definition of beyond pancreas? Surrounding structures including duodenum, stomach, colon, and spleen. But without involvement of the celiac artery or the SM. But if there is involvement of celiac artery or SMA, it becomes a T4 tumor. Take home exam point is that if celiac artery or SMA is involved, T4 tumor means non-operable. And this is what they are going to ask in the exam. So pancreatic tumor, pancreatic carcinoma is another carcinoma of the concepts of which you should know for your 2B exam. So I'm going to teach you a bit more about it. So please remember, for head of pancreas pancreatic carcinomas, classically, or neck of pancreas, we do Whipple's. Of course, if the tumor is in the body or tail, we can do different type of surgery, and in which we do cholidocogeginostomy, and then we can do gastrogeginostomy also. What does it tell you? You know, inherently, if the tumor has gone into the duodenum, you can simply remove the duodenum with the tumor. So it will still be a T4 and it will still be operable. And in the exam, you have to tell the examiner why a vessel is involved or encased or infiltrated. The criteria here is more than 180-degree interface between the tumor and the vessel. And please remember that the criteria, we also learned the criteria in CA esophagus, vis-a-vis descending aorta, and there the criteria was different. Interface more than 90-degree was abnormal, or means was positive. Between 45 and 90 was a gray area. Less than 45 was fine. But here we take 180 degree. Now look at this example. This is the tumor, and this is the vessel. This vessel, by the way, is SMV, superior mesenteric vein. And you can see the interface, and this interface is less than 180 degree. Look here, there's a tumor here, and it has got interface here, but this is less than 180 degree. On the other hand, look at these two examples. The tumor, it is surrounding more than 180 degree. Here, it is surrounding more or less 360 degree. So these are positive. So the slight difference between esophagus and pancreas in this category. And other signs which are also taken as signs of invasion, if a vessel is flattened like this, or there is a tumor thrombus, then you also say that this is abnormal. So these are the signs of vascular invasion. Please remember that historically speaking, if the superior mesenteric vein was involved, maybe 20 years ago, that was also considered inoperable type of a tumor. But now, surgeons have developed skills. It all depends where you are working, because they can remove the superior mesenteric vein. They can put in a graft, and usually up to 1.5 to 2 centimeter long grafts can be put. There are many technicalities. But the take-home point is that if a vein is encased, it is not taken as absolute, contraindication to surgery. It might still be possible. On the other hand, celiac artery and SMA are involved, then there is no hope. No surgery can be performed. This is a case where this is the celiac artery, and you can see that the tumor is completely encasing it. Take home, this is a very important slide where it tells you that if the SMA and celiac artery is involved, it is inoperable. If duodenum or spleen is involved, don't worry. Why? Because if spleen is involved, you can just do splenectomy with pancreatic surgery. Borderline tumors are these ones where the superior mesenteric vein or the portal vein or the splenic artery or the stomach and colon are involved. Look at this diagram here. The splenic artery is involved. So what can be done? That there can be surgery, just cut the splenic artery here and do splenectomy with it. So these are known as borderline. I don't think so they will ask you anything in this world. They will ask you if the SMA or the celiac artery. So I'm an examiner and I want to show you a pancreatic carcinoma. I'll show you something encasing SMA or the celiac artery, just to check your concepts. Okay, from here, we go back to the classification of pancreatic tumors, and we have got solid tumors and we have got cystic tumors. Now I go to candidate 7. Can you raise your hand, please? Thank you, candidate 6. Are you with us, candidate 7?
Yes.
So now we have got solid tumors and we have got cystic tumors here. So first of all, among the solid tumors, there are 2 types. One is pancreatic carcinoma and second is pancreatic neuroendocrine tumors. The concept is that the pancreatic neuroendocrine tumors can be benign as well as malignant. Extremely important for the exams, and I'm going to show you what can be asked in the exam. Now, first of all, candidate 7, can you tackle this film? So I've got an ultrasound image here, and I've got just one, late arterial phase, early portal venous phase type of a scan. Over to you.
So I'm presented with spot images from ultrasound scan and CT scan with arterial phase of a female patient with hypoglycemic attacks. On ultrasound, I can see an abnormal hypoaquic rounded lesion within the head or at the junction of the head and body of the pancreas. There is no significant ductal dilatation that I see on ultrasound. On the contrast CT, just where the normal vessels are at the junction of the head and body, I can see another hyper-enhancing area rounded in configuration.
What is your conclusion? Well done.
So my conclusion will be a hypoaquic mass on ultrasound, which is showing contrast enhancement in the arterial phase in the pancreatic body. So it would be a hypervascular solid tumor, which in pancreas are most likely the islet cell tumors or the neuroendocrine tumor cells, which are hyper-enhancing.
Excellent. So what we have learned from this case is that the 2 categories of tumor, one is what we call neuroendocrine tumors. They enhance. On the other hand, pancreatic carcinoma does not enhance. Now, if you see this chart, the neuroendocrine tumors can be hyperfunctioning and they can be non-functioning. But this concept is extremely important to remember. What are the rates of malignancy? And you'll be surprised to note that all of them can actually tumors. The minimum rate is insulinoma, and that is also up to 10%. But it can be more than that. And look at some of them. For example, ACTH-OMA, 100%, more than 90. So carcinoid is one of them. And they can be non-hyperfunctioning also. There are a lot of viva questions. Many a times they come in the exam. If you see what is written here, these are important points for you to remember. They can be, insulinomas can be part of MEN1 syndrome. Gastrinomas are very important for the exam. Concept to remember, they can be 60%, multiple in 60%. Concept of gastrinoma triangle is a key exam concept. Please remember that gastrinomas might be within the pancreas and they might be outside the pancreas, within an area which we call gastrinoma. So if you, and then because they can be multiple, you might pick up one, then the examiner is expecting you to pick up another one. And they can also have, part of MEN syndrome and extrapancreatic in 15%. All of them can have malignant potential. So basic idea is that if you pick them up, you do a bit of biochemistry, even if they are non-functioning, you can infer that they are, because of their enhancement, that they are neuroendocrine tumors. Venous sampling, etc., very seldom is done these days. At times, the patient is offered surgeries just on the basis of CTs. At times, there is a bit of role of nuclear medicine also. We will cover the nuclear medicine aspect of it in our session. But usually, you don't sit on them. You just get rid of them. Of course, in the real world, you know, at times you don't, because the patient is elderly or the patient doesn't want surgery, etc. So these are the various kinds of questions, etc., which can come in the viva. Another thing is that another difference with pancreatic carcinoma is that calcification is much more common. So they can have calcification. Please remember that adenocarcinoma of the pancreas can also have calcification, particularly because they might be associated with what we call chronic pancreatitis. But per se, tumor calcification is much more common in neuroendocrine tumors. And this is the gastrinoma triangle. And this, you have to remember this. And you can understand that an examiner will show you a tumor, which is, this is the duodenum and it might be sitting here. And your eyes will not go there. So you have to remember this gastrinoma triangle. Zollinger-Ellison syndrome, where there is a gastrinoma. Here it is sitting here, projecting into the duodenum. And with that, there is thickened Bruegel folds. This is the differential diagnosis of thickened Bruegel folds. I also showed you a case of Zollinger-Ellison previously. Okay, candidate 7.
Okay, so this is one of the magnified spot images from a contrast-enhanced CT scan axial slices. So there is a rounded lesion with the enhancement pattern almost similar to that of the pancreatic parenchyma, and it appears kind of exophytic from the tail of the pancreas. I can consider this to be a pancreatic neuroendocrine tumor. However, in this location, I should also be looking for any other lesion which can give this kind of appearance, or a normal variant maybe.
What is the normal variant?
I can think of splenectomus.
Right. Well done. So accessory spleen is a normal variant, and please remember that embryologically speaking, spleen can, there can be various portions of spleen in this region. And it has been, so many times I've seen that it has been wrongly interpreted as a neuroendocrine tumor. So keep your minds open. And this has come in the exam, and there is another scenario which I'll show you in the next slide, which has come in the exam more commonly. So point to remember is that on all sequences, the enhancement pattern will be equal to spleen. So what we do nowadays is that if somebody has reported it like this on a CT scan, just to confirm it, we do an MR. And it's simple as that. On all sequences, the lesion will be equal to the spleen. If you see an MR of the spleen, you will see that the diffusion weighted shows a bit of restricted diffusion. It is inherently bright on DWI spleen, and that is a very useful sequence to compare it. So that is a normal variant, accessory spleen. In this case, beware of this, and this has come in the exam many a times. And this is slightly different than an accessory spleen. This is known as splenosis. Basically, ectopic splenic tissue then growing up. So these patients usually have got previous history of, let's say, trauma where there is a splenic rupture. Now the splenic tissue has gone right and left within the abdominal cavity. And later on, they just grow. and when you do a CT or an imaging, you are worried about a mass. Another thing is that many a times post-splenectomy, you will see it. And I've seen one case which was very interesting, which was a gunshot wound years ago, and the splenic tissue was sitting in the thorax, just like this one from STAT DX, where something is sitting next to the heart. And so splenosis is a very, very important exam case. And if you don't know it, your mind will not pick it up. Yes, please.
So I'm presented with a CT scan, axial slices at the level of pancreas and kidneys, which shows a large, well-defined cystic attenuation lesion within the body and tail region of pancreas. There is slight, it is thin-walled, and there is very, very mild enhancement, maybe like anteriorly. The differential diagnosis for this would include pseudocyst, less likely an abscess, or a cystic pancreatic tumor would be in the differential as well.
If it is a cystic pancreatic tumor, which tumor?
Most likely mucinous, because they tend to occur more in the tail region. And I do not see any calcification on this one, but they tend to have mural and peripheral calcifications. So if there is one, it would suspect me more for mucinous.
Okay. So in your Chapman, cystic pancreatic lesions are given. I'll give you a slightly smaller classification of tumors part. But please remember that the most common cystic pancreatic lesion is a pseudocyst. And pseudocyst, by definition, they will occur maybe 6 to 8 weeks after acute pancreatitis. So classically speaking, in the viva, you have to tell the examiner that I'll correlate with the previous history. Is there any history of pancreatitis, etc.? But many a times you will see them incidentally. Also, there is a concept of true cyst in the pancreas. Some people think that this concept is not actually correct, but others feel that there can be true cyst. For example, in one Hippel-Lindau's disease or autosomal dominant adult polycystic kidney disease. And pitfall is duodenal diverticulum, where this is a case of autosomal dominant polycystic kidney disease, and with that there can be cyst in the liver as well as pancreas. Von Hippel-Lindau syndrome we will cover in our CNS module, where you can see that there is hemangioblastoma of the cord, hemangioblastoma of the cerebellum. Here is retinal vascular tumor of the right orbit. With that is cystic lesion in the pancreas. So von Hippel is a very important case. It can come in a long case also. Duodenal diverticulum. So the key thing is don't confuse it with a cystic lesion. Now, the final thing in the last 20-25 minutes is to cover these cystic lesions. And candidate 7, I'll give you just one more case, and then candidate 8, you should be ready. Now, if you see this, cystic lesions, or should I say cystic tumors here? So not lesions, but tumors. Can be serous cystic neoplasm, mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, and solid pseudopapillary neoplasm, SPN. Now, there is a concept that this mucinous as well as IPMN, these two can be benign, but they can convert to malignancy. Benign and convert to malignancy. Serous cystic, on the other hand, is just benign and there is no malignant potential. This one, I believe, is beyond 2B level. I don't think so anybody should ask you in the 2B. But I put it here just for completion's sake because it's a very interesting tumor. It is seen in young patients, 20-year-old females, And it's a very unique type of a tumor because of the age group, etc. They are always malignant, but the prognosis is quite good actually. Okay, this is your last case, number 7. Can you tackle this?
Okay, so I'm presented with a spot image from the CT abdomen with arterial phase contrast enhanced. There is an obvious abnormality, most likely in the head or body region of the pancreas, which appears multi-cystic with cysts of various sizes. I would measure, like in normal practice, how the largest cyst measures. And then there is a speck of calcification, a coarse calcification in the periphery. So since we are doing the pancreatic cystic tumor, so this most likely can represent a cystic tumor with a calcification. So could be serous cyst adenoma.
And why not a mucinous cyst?
Because the mucinous, they tend to have larger cysts, and the serous tends to have like smaller cysts. There is a criteria, I think 2 millimeter or 10, I'm not sure, I've forgotten that.
Okay, well done. So, is there any malignant potential if it is a serous? If you are right, is there malignant potential there?
No, as we just said that the serous are mostly benign in nature.
Okay, thank you. Number 8, you are next. Number 7, you can mute yourself. So, now, what are the take-home points as far as serous cystic neoplasm? So, if you see, first of all, these pictures, and you can make your radiology from here. First of all, a disclaimer is that in real world, at times we cannot discriminate between the two. But if you see a classical picture, and the examiner has to show you a classical picture for you to be able to pick that up. Now, this picture tells you everything, that it has got multiple small cysts. One thing which in radiology we give a lot of leverage is outline of the tumor. If the outline is lobulated like this one, you see the outline, it is lobulated. And why is it lobulated? Because there are multiple small cysts sitting there. On a CT scan at times you cannot see the walls of the cyst, but the lobulated outline tells you that there are small cysts. Look here, and you will agree that the outline is lobulated. Classically, the central part will have calcification, but all of these things are, with a pinch of salt, because everything is not classical in many cases. Now, they are slow-growing benign lesions. This is important. 75% in women, mean age is 62. So that is why we call it grandmom tumors. So 62 years. And they can be sponge-like and honeycomb appearance. Lobulated outline is one of the way to describe it in the exam. If there is calcification, it will be usually central, and it can be only seen in 18% of cases, because there is a scar here and there is calcification in the scar. The disclaimer is that at times they might be composed of just 1 or 2 cysts, and that is what we call the oligocystic type. What is the management? The management is that usually we do follow-up scans for these patients, but of course it all depends on anatomy. If it is more than about 4 centimeter, if the clinical presentation, if the location, we might do surgery. But remember that there is no malignant potential. This is a case on MR. And here, if you see on the T2, you are not very sure if you are looking at small cysts. But if you look carefully, look at the outline and it becomes a bit lobulated. On MRCP series, you can actually see multiple small cysts. So these are microcysts, and mucinous tumors usually have bigger cysts. Candidate 8, are you with us?
I can.
Okay, there is no history of pancreatitis. Over to you. What is this?
So in the body of the pancreas, there's a homogeneous, well-defined lesion with an enhancing border. The pancreatic duct doesn't appear to be dilated. I cannot see any calcification. And the patient does not have a history of pancreatitis. So my differentials would include a mucinous cystadenoma, given that it's quite homogeneous, well-defined, and predominantly centered on the neck of the pancreas.
What are you going to advise for the patient?
So if this is a first CT, I'd probably recommend an MR to ensure.
How will an MR help you?
Well, it might help narrow down the differentials if it's something else, such as a pancreatic collection or any other lesions, and it can also help define the internal structure of the cyst.
If you want to see inside, EOS is the king modality, and MR is not going to be helpful. You will be where you are. With clinical correlation, there is no history of pancreatitis. This looks like a cystic lesion with smooth outline, single cyst, call it a mucinous tumor. And these kinds of lesions, you cannot sit on them. You have to. So basically, this should be discussed in an MDT. And then you can make, do you want to do something, you want to do aspiration and confirm it, or you want to offer surgery, because please remember that they can degenerate malignantly. So if you see these pictures, and this one has got calcification, but this is peripheral. So the concept is that mucinous cystic neoplasm can convert to borderline tumors and then to carcinomas. The age group is slightly younger. So mean age group is 47. Remember, the serous tumor, the age group was mean 62. So that is known as grandmom tumor. This one is known as mom tumor. And exclusively in women. So some of the other, this is women, that was 75% women. So classical appearance is that it can be unilocular or it can be multilocular, but the cysts are going to be larger, and it can be very large also. So body or tail is more common. Smooth outline, you remember the outline of the previous one was lobulated because of small cyst. This one has got smooth outline, and the calcification is going to be peripheral. Signs of malignancy. What are the signs of malignancy? If there is wall thickening or irregularity, or there are mural nodules. To keep it simple, think like an ovarian cystic lesion. You remember that in an ovarian lesion, if there are, thick septations, enhancement, nodularity, enhancing nodule, you call it malignant tumor. Management, all should be removed, ideally speaking. But in the real world, everything is not ideal. But having said that, you should understand that this has got malignant potential. This is a very, very good case. And over to you. Then I'll tell you the story.
Okay, so this is a portovenous CT of the upper abdomen. There is a well-defined cystic lesion arising from the pancreas with a slightly irregular border. The lesion is homogeneous, well-defined. There appears to be some calcification within the posterior to the lesion.
That was in the vessel, so arterial. Don't worry about that.
Okay. The mass appears to be causing some local mass effect on the stomach, and there also appears to be thrombus in the main portal vein. Having a look at the liver, can't see any associated liver lesions. There appears to be some fat stranding, posterior medial to the lesion, and adjacent to the pancreas. And I think around the pancreatic head, there appears to be a hypoenhancing focus.
What is the conclusion?
So given that there's a hypoenhancing focus in the pancreatic head, I'll be concerned about a pancreatic tumor, an adenocarcinoma there. The cystic lesion, I'm not sure if this is a separate entity and represents a mucinous cyst adenoma with a pancreatic adenocarcinoma.
Or you're very, very close.
Is there a complication of the pancreatic adenocarcinoma?
Yeah, absolutely. This is